So let's start by talking about aortic stenosis and the disease. This is just a sample of what the aortic valve looks like when it's calcified and stenosed. On the right side is a severely calcified valve that has chunks of calcium, is very restricted, doesn't open very well. It's a disease that we all come across because it's very prevalent, affecting a large proportion of our patients, especially as they get older. It is a disease that is associated with wear and tear, deterioration of the valve. So it's more common in patients that are older, but other causes can lead to stenosis of the valve, including congenital abnormalities like a bicuspid valve, as well as infection. The risk factors for having aortic stenosis obviously go hand in hand with age. It is more commonly seen in male patients, and it is associated with hypertension, smoking, and high cholesterol, things that we know are not associated with healthy living. The symptoms of aortic stenosis, I'll just point out the trifecta of chest pain, shortness of breath, and syncope. Those are the cardinal symptoms that are very tied to survival. The way we define aortic stenosis is based on the findings on the echocardiogram. The guidelines I have up here are defined according to the ACC and AHA parameters of the echo findings. All the way on the right side, we're talking about a valve. We are talking about a valve that doesn't open very well, so the cross-sectional area is going to be very diminished. A normal valve will usually have about a 4 centimeter squared cross-sectional area. So once you start to get below 1, that's when we're talking about a restricted valve. And because the valve doesn't open very well, you're going to have high velocity across that valve of the blood ejecting from the heart. And this is what I was referring when you talk about the cardinal symptoms. Once you have severe aortic stenosis and you develop the symptoms of chest pain, shortness of breath, or syncope, the clock starts ticking, and the survival for these patients becomes very impaired. At 2 years, half of these patients without intervention will not be alive. However, we know that if you are able to fix the valve, if you can replace the valve, you actually kind of put them back on the timeline that they were supposed to be on if they didn't have the problem with the valve. So it's like you know, they fall off a cliff when they have symptoms, but you can put them back on the cliff and let them have the life that they were expected to have without the aortic stenosis. Just to, again, to put it into perspective, you can see that the outcomes of severe aortic stenosis rival those of advanced cancer, and it actually is a lot worse than some of the cancers that are listed up here. However, despite the fact that the outcomes can be very terrible, and you can have a great impact on the way people can survive and feel when you fix the aortic valve, we still have a lot of people, a lot of patients that unfortunately are not offered surgical repair. And different studies have shown that up to 40% of patients with severe aortic stenosis who are symptomatic do not have definitive surgery to repair their problem. And we'll talk about why that happens, but in essence, it's because of the associated problems that come with the problem of aortic stenosis. You have people that are old, that are very sick and have a lot of comorbidities. And there used to be a time when we thought that maybe not doing anything was probably the best thing for them. However, now we have some options. Up here, depending on where the patient falls on the risk profile, inoperable patients now have the option of undergoing a transcatheter replacement of their aortic valve. High-risk patients at this point have an option of having surgery the traditional way and also having the transcatheter aortic valve, which can be placed either transfemorally or transapically. The valve that I'm illustrating here is the Edwards Sapien valve, which is the currently commercially available FDA-approved valve for transcatheter aortic valve replacement. This valve is approved for use in patients that are considered inoperable and in patients that are considered to be high risk. I mentioned that there's two methods of inserting the valve into the heart. Currently, we can do it either transfemorally or transapically. And this is just a diagram showing how the valve would be placed from the femoral artery. And this is how we would place it transapically, essentially placing a small hole or making a small hole opening on the left side of the chest and actually puncturing the left ventricle somewhere near the apex and then placing the valve in an antegrade fashion. And just to kind of illustrate how it's done, this is a valve that's being placed from the femoral artery. The heart is actually paced rapidly with a transvenous pacer, and the balloon is inflated across the aortic valve, which opens up the stent carrying the valve. Once the balloon is deflated, the valve starts to function immediately. So once the heart then is no longer being paced, it resumes its own conduction and its own rhythm. The valve immediately starts to function, and we see improvement in the hemodynamics immediately. So who can gain the benefit of a transcatheter aortic valve replacement? Currently, we have patients that are inoperable, meaning that their risk for mortality or serious morbidity at 30 days is greater than 50%. And I will list a few of the things that we consider when deciding on the risk of patients, but some of the characteristics that can make people inoperable include having a severely calcified aortic valve, a so-called porcelain valve, having severe lung disease, or having multiple comorbidities. Having a high degree of frailty can also impact on their ability to undergo surgery. High-risk patients are those patients that are judged by we have a tool that we can plug in all their characteristics to say what their risk is of having serious complications from surgery, and it's based on the database of the Society of Thoracic Surgery. And when you plug in the patient's characteristics, it'll tell you their percentage of having a mortality or serious complications. So the high-risk patients are those that have an STS score that's over 8%, or in the assessment of cardiac surgeons, that their risk it would be greater than 50% at 30 days of mortality or serious morbidity. So up here, this is kind of the bullet point to take home. The patients that so far haven't been offered surgical intervention for the aortic valve are people that are obviously going to be very old. And remember, this is a problem that comes with age. So a lot of the patients will become symptomatic in their 80s. But what we tend to see now is that sometimes people will become symptomatic as we tend to live longer into their 90s. Having diabetes, hypertension, having PAD, having had strokes, having severe lung disease, having congestive heart failure, and having a very diminished systolic left ventricular function are all parameters that come into play that put your patient into a very high risk category, or possibly even into a inoperable category. So I mentioned this briefly, but when we see these patients that are referred for assessment for aortic valve replacement, we take an approach of assessing the entire patient as a whole. We calculate their STS score, and then we also take into account things that are not considered by the database, that are not considered by the score, whether they have a calcified aorta, whether they have an anatomy, a chest anatomy that's not amenable for surgery. Maybe they have had radiation in the past, or maybe they have had previous surgery. We obviously will look at people with things like liver disease and severe COPD. Dementia will come into play as well. People that have been moderately demented, or perhaps having multiple strokes in the past, were not deemed to be able to go through a bypass surgery, where sometimes you can have a quick progression of their cerebral disease after after having been placed on the bypass machine. And then you have people that are incredibly frail. Sometimes you can have somebody who's very weak, very low functional, who we need to consider whether they would be able to go through surgery and not just have the surgery, but then actually go through the rehab process to recover from the surgery and not then succumb to a post-operative complication. Now, we kind of put these patients on a range of risk stratification, and on the left here, we had people that in the past perhaps they wouldn't be able to get surgery at all. Now they can potentially be treated with TAVR. But obviously, as you get sicker and sicker, we still have to use judgment and maybe leave well enough alone and not offer them the TAVR. So even though it's a procedure that makes the treatment more readily available, it will not cover or treat absolutely everybody. And one of the things that is very important is that when your patients are evaluated to have this treatment or this therapy, they will be evaluated by a team. So it's in Vincent's, much like any other TAVR center, the patient is seen and evaluated by cardiovascular surgeons, by cardiologists, by the anesthesiologist, as well as an echocardiographer to make sure that the patient is appropriate to undergo this treatment. Now, why is this something that is now offered? Why are we treating these very sick people? Because now we have data that shows that people do better when we treat them with a transcatheter aortic valve replacement. The key trial is the partner trial that had two groups. This is the first group where they looked at inoperable patients that were not offered surgery in the past. And they randomized people to be treated by medical therapy or standard therapy or to undergo TAVR. After they had gone through a selection process to make sure that they could have the valve replaced via the femoral artery. And this is data now going out to 2 years showing that the replacement of the valve by the catheter method actually has a marked improvement on their outcomes. So without treatment, 50% of them, as expected, are not alive, but that is actually significantly reduced, and we are seeing that hold out to 2 years. We don't have to treat that many people to actually gain a benefit. We can treat 4 people in order to be able to save a life. The other part of the partner trial was the group where they looked at the high-risk individuals. And those were then compared to traditional open heart surgery. And the goal of the trial was to show that it was equivalent or not inferior in outcomes. Within the group, they actually stratified them based on their access. So whether they could have the valve placed through the femoral arteries or through a transapical approach. And this is obviously based on the size of the arteries, the extent of PAD that they have, and whether they can accept the large catheter size that presently are needed to deliver these valves. And now this is data that was presented earlier this year at one of the conferences, the ACC conference, that actually shows now data out to 3 years where the survival is equivalent between TAVR and surgery in the high-risk population. This is showing how the symptoms also improve. So not only are we improving outcomes, but their symptoms are also improving. And we're turning people that are mostly class 3 and 4 CHF, that's your yellow and orange there, to mostly class 1 and class 2 heart failure individuals. That's your green and your dark green and light green there, all the way out to 3 years on the right side. Now, this is a treatment that obviously has to be taken with caution, and that's why right now it requires a team approach to make sure that we can treat the individual properly. One of the things, a couple of the things that we're seeing are that strokes can be higher with the TAVR than they were with a traditional surgery in the immediate postoperative period, and that's because a lot of different factors, but mostly because of the bulky device that we're pushing up the aorta and into their ventricle, as well as the fact that we're blowing up balloons, cracking open the valve, and possibly dislodging some of those chunky calcium particles that I showed you at the beginning. And so initially, we're seeing an increase in the rate of stroke post-procedure as compared to traditional surgery. However, over time, what we're actually seeing now going out 3 years is that the rates of stroke, although it's initially higher, it actually remains a little bit more stable over time, and surgical patients actually tend to catch up. And some of this stuff is being teased out, but part of it could be that we see higher rates of atrial fibrillation develop in the surgical patients, which could account for the fact that they are now having higher rates of stroke later on. In terms of the other thing that I think is key is the fact that, again, we're talking about patients that are very sick. We're dealing with very large catheters. And some of the key things that include vascular complications. So initially, they're very high with the TAVR. So which is why it's incredibly important for us to have a careful assessment of the patients, not only clinically by the doctors, but they have to undergo assessment with CT scans to be able to determine which access point is actually the best for the patients. However, at this is actually going out to 3 years. Some of the key things, including endocarditis or complications of the valve, including the need for surgical or subsequent repair of the valve, actually is incredibly low and very equivalent between the two treatment modalities. And just to show, one of the concerns when we started doing these valves is, well, they're being placed with a balloon, they're crimped, how are they going to function over time? And over 3 years now, these are some of the parameters looking at the actual area, the cross-sectional area. So over time, they are actually equivalent to what you actually get with the surgery. And parameters including the hemodynamics, so how blood is flowing through the valve, is also quite impressive and remains stable and equivalent to what you're getting with the surgical valves up to 3 years also, which is actually quite reassuring because, these people are actually living longer. You want to give them a valve that's going to be good for hopefully the duration of their life. And that's really all I wanted to say. So the key point is that you have options for your high risk and your inoperable aortic stenosis patients, and we're obviously available to consult and to help in taking care of your patients.